Everybody here, I got Dr. Jerald Simmons with me today. And we are going to talk about this Netflix movie called Open Wide, which came out not too long ago. And this is interesting because Dr. Simmons here is a board certified neurologist in sleep and epilepsy in neurology. And a lot of people have been texting me when this documentary came out is about what I thought about it. And they also texted me what does Dr. Simmons talk about it. So, Dr. Simmons lives a few streets down from me. So I thought I'd invite him into our home today to actually talk about, this concept. But what I didn't know is that he got to meet the hero of the story on the Open Wide on Netflix just a couple weeks ago. You said? Yeah. But let's talk about that real quick. So this Netflix movie, Open Wide, if you haven't seen it, go check it out. It's kind of all over YouTube and Netflix and discussions on it as well. And the term mewing has been this viral hashtag that's been on TikTok and Instagram for a little while now. And the question is, well, how did it get here? And there's some controversy within the community about what it's supposed to be. And it really challenges traditional orthodontics. But why are two MDs talking about something that's in orthodontics and dental medicine? Because the teeth is not a siloed, standalone thing that is not connected to the body. The teeth is, and the airway is very much connected to the rest of the body. So let's kind of dive into that, Dr. Simmons.
Great.
But tell us, this Netflix documentary called Open Wide, it talks about how traditional orthodontics, which is sort of fixation of teeth in place, is really more focused on making sure the teeth are there, it's healthy, but really solely focused on this area. Mm-hmm. But there's an entire concept of skull formation, of airway that's not really talked about. And it's not something I even learned about in medical school, but you've been talking about since the 90s,
Yes,
right?
correct.
And so let's talk about what that really means. And
Like you pointed out, you can't look at the teeth in isolation. Teeth is part of the body, part of the airway, the front end, really.
Yeah.
And when someone has malocclusion, their teeth are crooked, crowded. If the practitioner, the orthodontist, were to deal with that as an isolated phenomena that they're trying to fix, and if they took the approach, well, let's take out some of these extra teeth because there's crowding, and let's bring the teeth together to make a nice smile. The smile may look nice, but what's happened in that scenario is airways become even more compromised. It's already compromised. And then by taking out teeth and bringing things back, you've now made it worse. And it's become real clear that what occurs in the mouth is going to influence how you sleep, which will then influence the rest of your health. So Dr. Mew, years ago, realized that there was a problem here.
Yeah.
And he obviously was not his concepts and ideas were not welcomed within the standard traditional orthodontic community. But now let's fast forward to where we are now. And it's really clear that even physicians recognize that we need to open up the airway. And we need to take a different orthodontic approach to not extract and retract, but to expand and allow room for the teeth. Because in so doing, you're allowing the tongue to come forward, you're allowing the airway to open up, and then you're going to breathe better, and that will have its impact on sleep, and you'll end up sleeping better.
Right. But, the fact that two MDs are talking about it is kind of a big deal because, let's talk about this for a second. Like, why will you, a neurologist, care about orthodontics? Yeah.
Well, because it's part of the body. I mean, you can't function in a silo. Yeah. And I recognize the impact. I mean, for example, grinding, clenching, looking at someone's teeth and seeing the enamel all worn down. Why is someone clenching? And when you take the history, most of these people are doing it in their sleep. So what's going on during sleep that's triggering this clenching, grinding phenomena? And then people say it's stress. Well, if it's stress, you'd experience stress during the day. They're doing it during the day. And a lot of these individuals are doing it to try to help open up their airway because their airway is compromised. And when the jaw falls back, the base of the tongue goes back, so the airway is more challenged. So by clenching and bringing your jaw forward, it actually can bring some improvement in airway function. So as a neurologist, I care about it because if my patient's coming to me with morning headaches,
Yeah.
right? Every morning they wake up with a migraine headache. Well, if I don't recognize the red flag that it's in the morning after they're supposed to be resting and sleeping,
Yeah.
if I neglect to take that into consideration, the time factor, and I just put them on medications to treat their migraines,
Yeah.
I'm going to put this patient on so many different medications, and I'm not going to get the root cause of what's the triggering factor,
Right.
and that's their abnormal sleep.
Right. Well, I mean, we talk about migraines, but there's other implementations, especially in mental health as
Right.
well, right?
Totally.
Such as inattention or ADHD and stuff like that.
Well, clearly, I mean, we talk about how there's such an overutilization of stimulant medications in our society and how all these kids are being put on stimulants. Well, they're missing the point that a lot of these features that we're calling ADHD and ADD, those are symptoms of dysfunction in most patients. So it's not the problem in and of itself. It is a manifestation of another problem. And in at least a third of these kids, it's from not getting proper sleep.
A third.
At least a third.
At least a third. But this is not, it's sort of a controversial topic, but this is not known in psychiatry.
It
right?
should be.
It should be known in psychiatry.
Well, so I welcome people to come to. We do a conference. I'm trying to raise the level of knowledge in our healthcare community. I've been doing this for years. I used to be in academics. I was on faculty at UCLA, and then when I came into the private sector, I still wanted to teach. 20 years ago, I started a nonprofit organization, and we do a conference every year. It's coming up actually this April. The organization is the Sleep Education Consortium, but we want physicians and dentists and other healthcare professionals to come to this conference to learn about sleep disorders because it's not taught very well in our healthcare educational system. And all psychiatrists and pediatricians need to know that sleep disorders need to be considered. And any child that's coming with poor behaviors during the day, you can't just reflexively put them on a medication. You have to at least take a sleep history.
Yeah.
And then you're going to find out that the child has a hard time going to sleep, and then they're tossing and turning through the night. Maybe they're snoring, maybe they're mouth breathing, they're drooling on their pillow. It's not normal to breathe through your mouth. It's normal resting breathing is through the nose. So when you're reflexively opening up your mouth on a regular basis, that's a red flag that there's a compromise. But these children are having a hard time waking up, and they're having symptoms of dysfunctional sleep. And the stimulant medication is going to be a pharmacologic way of masking those symptoms, but it's not really getting at the cause.
Right. Not looking at the root cause, masking symptoms. And, beyond even the stimulant prescriptions, there's also caffeine that's a stimulant that people are using too, right?
Yeah. We, as a society, we're addicted to our vitamin C, right? Caffeine. And look at, companies like Starbucks that do a phenomenal amount of business because people were walking around pretty much as a sleep-deprived society, whether it's just we're just not giving enough hours to sleep or there's some dysfunction to our sleep, so the sleep that we get is not restorative.
Gotcha. And let's go back to the documentary. Open Wide, John and Mike Mew talked about how most people have some sort of a sleep disorder breathing phenomenon, right? And is it as common as they say in the documentary, or what do you think about it?
Okay, I think it just came out this past week.
Yeah.
I think they said that most people's faces are not completely normal, but that doesn't mean that most people are going to have a sleep-related breathing disturbance. But it does mean that maybe there's some level of optimization that could take place. But really, the issue is that there is a spectrum of the degree of abnormality. That's only one spectrum is airway dysfunction. The other spectrum is brain sensitivity. So one person's brain may be more resilient against feeling the ill effects of fragmented sleep, whereas the next individual may have a very sensitive brain where if you disturb their sleep just a little bit, they're going to be devastated the next day.
Right.
I guess a similar concept can be used from a digestive standpoint. You can have one individual who's going to eat steak and potatoes several times a week and their cholesterol can be fine.
Right.
The next person can have the same diet and their cholesterol is way out of whack. So everyone has a certain genetic construct that they come into a scenario with. And so some people are more predispositioned to feeling the ill effects. So if you have a brain that's more sensitive to feeling the ill effects of fragmented sleep, you only have to fragment the sleep a little bit to start having significant symptoms. So there are some people that have significant abnormalities of their airway, but their brain is real resilient. And so they may not have any real symptoms. They're going to feel fine. And so then people that are looking at this concept are going to say, oh, this is just not true. Because look, you've got this abnormal airway. Look at this person's anatomy and they're not having any symptoms. So therefore your whole concept is just, wrong. No, you got to look at all the different pieces of the puzzle to understand this. So, so there are a lot of people that have some degree of airway compromise. So the most important thing is if you've got symptoms, then you need to start looking at the airway. And then when you put two and two together, you should definitely intervene when you've got a compromised airway with daytime dysfunction. Ideally, it's best to get a test done to establish objective parameters that are abnormal. And then you could follow that as you're going forward with treatment. But this brings up an important point, though. What if you do have abnormalities in your sleep, but you have no symptoms? Doesn't mean you shouldn't treat. And in some instances, maybe you should, because you may decrease the likelihood of cardiovascular disease down the road. But if it's real mild obstructive breathing, then maybe not. So if there's a mild degree of obstructive breathing in an asymptomatic patient, maybe we just follow the degree of obstructive breathing over time, let's say with a repeated home sleep study every 1 or 2 years. It's a simple thing, you're just checking it like you're going to check any other test. You get repeated tests to follow the degree of the abnormality. And if it gets to a certain point where you're not worried about it developing into cardiovascular disease, you can intervene. But if it's really bad, I have some patients that have no symptoms and they've got really severe apnea.
Well, we have to define symptoms because
I
don't think people really know that they have symptoms of impaired quality sleep, because it's not usually categorized as impaired quality sleep, right? And we talked about like mental health diagnosis. A lot of people with chronic anxiety, nighttime awakenings, people with PTSD. We're not saying that, oh my gosh, all of these disorders are caused by impaired sleep, but that is a huge component to improving people with these mental health issues, right? And so, but let's talk about what the actual symptoms are. And instead of just categorizing as anxiety or post-traumatic stress or depression, what should people really look out for to know that they can potentially have an impaired quality sleep that's not popularly known?
Okay, well, let's start with the basics. Let's say you have difficulty staying asleep through the night.
Right.
So you fall asleep and then you wake up every 2 hours.
Yeah.
That's not normal. Okay. Now you may go right back to sleep.
Yeah.
But what caused the awakening? Now, if you're a middle-aged person, you should be able to clearly sleep through the night. As you get older, there are other things that may occur. You may get some arthritic conditions or other things
Arthritis,
that may, pain could cause the awakening. But still, that's an abnormality. It may be common, but it's something to consider. But it could be something like sleep apnea. And whenever the person goes into REM sleep, for example, during REM sleep, your muscles are more paralyzed, and that includes your upper airway muscles. So sleep apnea is typically at its worst during REM sleep. So someone is going to go into REM and they have bad apnea, boom, it wakes them up. And then about an hour and a half or so later, boom, it happens again. So awakening out of sleep repetitively is one consideration.
Yeah.
Another might be, waking up with headaches, as I mentioned earlier.
Waking headaches, yeah.
Okay.
The morning headaches, yeah.
Or even reflux, GERD symptoms.
Acid reflux, yeah.
So if your acid reflux is primarily at night, and even if you try to, limit the amount of food you have at night before going to bed, you're still waking up with the reflux. The concept behind why this is happening is because as you breathe and air rushes through the back of your throat, there's a vacuum, a negative pressure from the flow. It's called the Bernoulli effect. As your airway becomes more narrow, then there's a stronger vacuum, a stronger negative pressure that gets created in the back of the throat by trying to get the same amount of air through a smaller space. That negative pressure is disseminated into your whole chest cavity. So your chest becomes like a vacuum chamber. And so if you've got a slightly incompetent lower esophageal sphincter, it's at the end of the chest, right above the stomach, at the end of the esophagus. If it's slightly incompetent, that vacuum in your chest is going to suck the juices from your stomach.
The acid up.
Exactly. So you're going to have reflux. And, and the gastroenterologists, the GI doctors don't really, a lot of them are not aware of this association. So when someone says they have GERD symptoms, gastroesophageal reflux disorder, rather than just giving them a medication, a few questions are important. It's like, does it primarily occur at night? And if it does, then ask one other question. Do you snore? And if they snore and they've got nocturnal GERD, they need a sleep study.
Yeah.
It's that simple.
Yeah.
So GERD would be clenching, grinding,
Yeah.
and in sleep is another symptom. Waking up with a dry mouth or nasal congestion. Let's say you go to bed, you're not congested, but you're waking up with this congestion because the obstructive breathing during sleep is causing inflammation in the upper airway.
Yeah.
And that vacuum, that negative pressure. And so that as the tissue of your sinuses starts to get more congested, you'll wake up and you're going to wake up with nasal congestion. And then typically in that scenario, the congestion resolves after 1 or 2 hours of being awake, maybe even less. So if you have that pattern, you're waking up and your congestion is the worst, right? First thing in the morning, you want to consider maybe obstructive breathing during sleep. Fatigue, daytime sleepiness fatigue is a real common one. You sit down, you're relaxed, and you start dozing off. You can't read through a novel during the day. You're constantly moving. Some people will avoid certain behaviors because they know that they're more likely to trigger sleepiness. So,
Yeah, that's me. I just have to keep going, otherwise I'll get sleepy.
So it's one extreme or another. Either you go or you're out.
Right.
And so, but that would be a symptom of obstructive breathing during sleep. And there's abnormal behaviors during sleep. People are, talking and thrashing around in their sleep. Could be that restless leg syndrome is another, not related to airway, but it's a real common problem where people, when they're lying in bed, they're moving their feet around. They just don't feel rested and settled. So there are a variety. I mean, there's many more symptoms, but I think we've hit, some of the big ones.
I think another big one is that a lot of times people say, I'm a great sleeper. I never wake up, but I require like 10 hours to even fully feel or even partially feel rested, right? And they're like, I'm such a great sleeper. How can I have a sleep issue? Like, what do you say to that?
Okay, so yeah, I've heard that many times. They'll say they're so great that they can sleep anywhere, anytime.
Yeah.
Right? So that's a sign of an abnormality. You shouldn't be able to fall asleep in the middle of the day. If you're well rested, you really shouldn't have a propensity to be able to fall asleep.
Yeah.
There's actually a test that we call the multiple sleep latency test. It's what we use to establish a diagnosis of narcolepsy or a diagnosis of idiopathic hypersomnia. So in that test, a person, after having been monitored all night long, then during the day, there are 4 or 5 napping sessions every 2 hours. We turn off the lights and the patient's all hooked up and we say, go to sleep. And if they fall asleep on average less than 15 minutes on those napping sessions, that's abnormal.
Yeah.
Because it's normal to take longer than 15 minutes to fall asleep. So someone that says that they're a great sleeper, they're going to fall asleep within 2 or 3 minutes. That's abnormal. Then they now can be labeled as having either idiopathic hypersomnia or maybe even narcolepsy if they go into REM sleep within a short period of time after falling asleep on those naps. Because narcolepsy is another discussion, but it's a condition that's highly underdiagnosed.
Right. And let's go back to this mewing trend, because I think on TikTok, it's got billions of hashtags at this point. This mewing trend is basically discussing techniques to shape someone's jawline through different tongue placements and stuff like that. So there's a whole body of therapies, which is called oral facial myology or myofunctional therapy, that actually is part of this, not just for the jawline, but actually get people to breathe better, right? And so what do you think about this mewing trend and where it's going right now? And how do you think it implicates everything that you do as a neurologist?
The fact that there's this interest is because it's addressing an issue.
Yeah.
Now, clearly, exercises of the upper airway can improve respiratory function, breathing function. Myofunctional therapy is a great method of therapy to add on to some other mode of therapy, because myofunctional therapy in and of itself, if someone has obstructive sleep apnea, myofunctional therapy in and of itself, in most cases, is not going to be adequate to resolve the problem. But yet, if you're going to treat with a dental appliance or treat with CPAP or treat with any other, mode of therapy, you'll get better outcome if you're adding in myofunctional therapy because you're working with muscles. Tongue placement, like tongue resting posture, that's not taught in medical school. That you're going to breathe best if your tongue is on the roof of your mouth forward, because it's going to help open up the back of the airway. So tongue posture and then looking whether there's restricted soft tissue restriction of mobility of the tongue, whether your frenulum is restricted. There needs to be proper mobility. So the whole issue with the mewing, I think, is interesting, and it's good. It's not the whole picture,
Yeah.
but it's not bad in any way by doing these exercises. The other thing that's important to realize is that muscle beats bone. And if there's going to be a tug of war, I mean, in other words, you can use your muscles to change the shape of your bone. So when a child is tongue thrusting because their tonsils are enlarged, that thrusting is going to change their teeth. They're going to end up having this open bite, and their teeth are going to be crooked because their tongue all night long is pushing. So the tongue pushing over time can actually cause abnormalities in the bone. It changes bone structure. And if your tongue is not going to the top of the roof of the mouth, then the roof of the mouth is not going to form correctly. You need a nice formed arch on the upper part of the airway. And if your tongue has a bottom resting posture, not going up, you're not pushing it. It's not going to change the bone. So so there are now people that recognize these important relationships, and actually orthodontics, the optimal time, and this is controversial. I'm not an orthodontist, but I understand the physiology and a big, comprehensive kind of picture. And it may be that the best time to introduce orthodontics in a child would be maybe starting when they're 3 or 4 years old, rather than waiting for all the adult teeth to come down, because by then a lot of the damage has been done. You could actually open up and make more room for the teeth if you start intervening at an earlier age when the bones are not all fused and there's a lot more mobility that can occur, and you can open up a child's airway a lot easier. So it's a matter of identifying which children are at risk for needing this.
Right. And what we're talking about here is something that's very important, because this is not just about airway and sleep, because a lot of this contributes to a lot of chronic pain disorders, fibromyalgia, chronic TMJ issues, migraines. So the way that orthodontics is done conventionally has been working on, let's say if an adolescent or child has very small or crowded airways, then they pull out teeth to kind of fit everything in nice and neat. But the problem is a lot of the orthodontics is done during the growing period. I know when I was 11 years old to 13 years old, I grew a foot. I was 6 foot tall by the time I was 13. And so there's a lot of space to move for the mouth and the airway a lot. But, the problem is sometimes when you have orthodontics that's fixating that area, it may be causing some issues. And this is what's the trending and controversial topic, right now. But the idea behind this is, for what I do in internal medicine, is we look at all the diseases that have really difficult answers for, like chronic pain and fibromyalgia, POTS, dysautonomia, Alzheimer's disease, right? And there's an airway component to each one of these that's rarely is it really addressed. And if you talk to, let's say, a rheumatologist, this is sort of a new understanding for them as well, is, hey, how can we help your fibromyalgia patients? And there's sort of a question mark as to how is the airway really related to us. There's a huge relation to it. If we talk to a psychiatrist, right? And eating with, especially like adolescent eating disorders, anxiety, ADHD, talking about even tics, and all these different things may also have an airway component to it. And so we have to work together from the MD side to the orthodontics to every specialist, so we can actually solve these larger problems that seemingly aren't related. But now I want to talk about the Sleep Education Consortium, because this is the 20th anniversary this year. 2024 is the 20th anniversary. So you've been trying to get this out for 20 years. I wish the documentary was made on you. You've been trying to get this idea out for 20 years. And even when you were at UCLA, you wanted to have some grant funding to teach dentists on how to improve the patient outcomes, right? And so you were the cowboy at that time and the controversial character, right? Tell us about that journey and the history of the Sleep Education Consortium.
Well, so I'll first touch on some of what you just mentioned about. So when I used to be on faculty at UCLA, co-directing the Sleep Disorder Center there, and the NIH had an announcement for a Sleep Education Award to help educate healthcare professionals and medical students and It was it was recognizing the deficiency of education on sleep in our system. So I submitted a grant, but I had about a third of the grant focusing on educating dentists because it's the same concept. I realized that the dentists are right there looking at the airway. And if they knew how to screen for sleep apnea, it would identify a tremendous number of patients that are suffering from this problem, because the dentist looks at the mouth of every one of their patients. Physicians don't necessarily look at the mouth. And if they do, they're not necessarily looking at the right parts of the anatomy to understand about sleep apnea. But anyhow, half the reviewers thought I was a genius. The other half thought I was a misguided physician. Spent too much time trying to educate dentists, and I need to focus just on physicians. Well, so obviously I didn't get that grant. But here we are, years later, basically 25 years or so later, and sleep dentistry is really booming because there is this need, and physicians have not embraced the screening process of sleep apnea. So many times the patient's only going to get their sleep disorder identified because the spouse is complaining about snoring, and it's not all about snoring. And there's a lot to understand there, and it's also important to understand that not all sleep studies are the same, and a home sleep study is not as sensitive as coming into the lab, and even that, not every lab scores using the more sensitive criteria. But anyhow, recognizing that there's a deficiency in healthcare education on sleep, when I transitioned out here to Texas, I still wanted to educate, and I was being asked to give lectures here and there, and just decided, I'm going to start a nonprofit organization that's going to do conferences every year to try to raise the level of awareness on sleep to the healthcare community. So in 2004, we had our first sleep education consortium conference, and Dr. Todd Swick, who's no longer is in the Houston area, but had been in Houston for many more years than I approached him on this, so he helped me with the early stages of this conference. But anyhow, so here we are 20 years later. Now, the concept of including dentists was right there from the get-go, because actually, while I was at UCLA, and I realized, actually, when I was in my training, I realized the whole concept of dentistry. Actually, I'll go back. One of my patients, when I was doing my fellowship at Stanford, who had real bad TMD, and she was a patient referred over by Dr. Powell. Riley and Powell they pioneered surgical management of sleep apnea patients, and they were dentists and ENT surgeons at at Stanford University. Mm-hmm. Anyhow, so Dr. Powell sent this patient with real bad TMD. I got her history, and we decided that during her sleep study, we were going to put a few extra electrodes to really measure her muscles of mastication, to measure her bruxing.
Her grinding.
Right. So I was real impressed when I'm looking at the sleep study. She's clenching, you can see the increased activity, and there was very little apnea. And all of a sudden, the clenching stopped. Apnea, 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 apnea. Then the clenching came back in, and then the apnea went away. And it's like, wow, there's this inverse relationship between her clenching and the degree of her apnea. So that I remembered that, and then as time went on, I realized, the role of dental appliances to stabilize the manual, and maybe you can resolve the problem by bringing it forward at night, but just even to stabilize it, even in conjunction with CPAP, can be useful. So anyhow. So Dr. Rob Vies, who's a dentist in California, he's actually now the CEO of a company called Space Maintainers Laboratory. They make a whole spectrum of different type of dental appliances. So they're not a one type of appliance company. Mm-hmm. They make a whole spectrum. Anyhow, I got involved with putting together some educational materials for them to help educate dentists. And this is before I came out here to Houston. Then when I came to Houston, I wanted to continue this journey of educating, and I included Dr. Vies. We got dentists involved. And as time went on, from 2004, each year there seemed to be a greater interest by dentists. Mm. And then it got to the point where, there were so many dentists that were actually coming to this conference to learn about sleep. Fast forward, there's right around 2012, 2013, Texas Dental Board was reviewing the role of a dentist in sleep medicine, because at the time there were no guidelines. Mm-hmm. And so the board decided that they were going to look to see, should dentists be involved in dental sleep medicine? And if so, is there any kind of criteria that should be met in order for them to practice? Well, I was asked to give testimony at the dental board meetings in Austin. So I went there, and And lo and behold, they call me first to get my, when you have like the public portion where you can talk about your view on the topic.
Right.
So I gave my whole thing about how I think dentists need to be involved, but they shouldn't be doing it independently. They need to be working in collaboration with physicians.
Right.
I was really impressed over the next hour or so when all these other dentists kept on coming up that I didn't know. They're kind of saying, I went to Dr. Simmons' course, several years ago, and it transformed my practice. I mean, I was really humored and very gratified to see how much of an influence this conference had. Well, the president of the dental board at the time, Dr. Ramos, he came to our conference for the next 2 years as they were working on changing the rules. And he said that tremendously influenced his perspective. And now Texas actually says that if a dentist is going to do work in dental sleep medicine and make appliances, they have to do it in conjunction with a physician, but they also have to have 12 hours of CE experience to do this. And whereas most states don't have any requirement, meaning any dentist can get involved, but Texas actually has some guidelines. There are other states now that have followed suit and done this, but Texas was, like, I think, the first. And this conference actually had a lot of influence on the development of that.
Well, that's great. So let's talk about this conference, and you were kind enough to let me speak last year, so thank you for that. My topic was hypersomnias. But this conference is actually the gold standard, I would say, of collaborative medicine. And in fact, this conference is the actual glue that allows the collaboration between not just physicians and dentists, but even different specialties within dentistry and physicians, right? From psychiatry to pediatrics, to internal medicine, family medicine, sleep medicine, neurology, rheumatology, right? Because all this is really affected because, in my background, and I come from 6 generations of Chinese medicine, is whenever the qi is blocked, it's usually blocked at the origin. And that's usually has to do with breathing and nighttime breathing. So even 5,000-year-old Chinese medicine really has a big focus on the actual breath. In fact, even in ancient China, they now take babies to induce nasal breathing. Infants, actually.
And here we are years later. People are starting to do that again.
Yeah, exactly. And from a collaborative medicine standpoint, I think like the way that we have to look at society is that there's no other way to proceed forward other than collaboration in the field of medicine. And the age of just putting diagnosis on symptom clusters and calling a name and having that tie medication to it, like it's about to be over. Because we are now at the apex and the limit of what pharmaceuticals can do. We have to look at root causes, and there's no better place for anything on airway and sleep related in relation to all other types of medicine than the Sleep Education Consortium. So I want everyone to come. And for those of you who are watching, the link is actually in the description below of the 2024 Sleep Education Consortium. Another thing I want to talk about is specifically which type of physicians can actually benefit in our physician community. Because right now there's a lot of dental community that are really aware. The physicians community is still a bit behind, I think, in understanding their specific role and how airway really affects a majority of what they practice. So let's start with some specialties that you wish were represented more in the Sleep Education Consortium.
In terms of attendance?
Yes, yeah.
Okay. Well, pediatricians.
Because
it starts when you're a little kid. I mean, you could prevent so much.
Yeah.
You can prevent the burden of sleep apnea if you can intervene, identify and intervene early. Also, psychiatrists have to have a better appreciation. Cardiologists. Yeah. Because of the impact on the heart.
Well, let's go to pediatrician and psychiatrist for a second, right? Because one of my friends is a pediatrician, and he's just sick of just writing Vyvanse for all the families that are kind of demanding it, right? And because the fact that there's a much bigger view to it. So this is in the field of psychiatry and pediatrics, especially with adolescents and the prescription of the stimulants, right?
Right.
And so I would say, well, I don't know if you agree with me, but you almost have to rule out some sort of a sleep disorder prior to prescribing that, right?
You at least have to take a history.
Yeah.
And then if there are things in the history that are red flags that there's a sleep disorder, then you should refer on to the sleep specialist.
Yeah.
I don't think that the pediatricians may say that I'm too busy. I don't have time. I've got so much that I got to do.
Right.
Just you could do a quick little screening assessment and then refer to the sleep specialist. Let them deal with it. Let them follow. Sleep specialists are not just a test.
Yeah.
Unfortunately, people think that the sleep facility, they just do the testing and then the management comes back to the primary care doctor or the pediatrician. Well, if your sleep center is not providing assistance for management, then it's not a real sleep center. It's just a testing facility, and I would go somewhere else. You really want a clinician that wants to embrace the outcome and will help you with the management, because even things like CPAP, it's not real simple. Just put on a mask and then just rely on the home healthcare company to manage it. The clinician, there's all these little nuances to that. And so the outcome is better when you have the proper kind of specialist managing it. So pediatricians,
Yes.
and psychiatrists would be real big, and a lot of kids with depression or bipolar.
Yeah, bipolar is a big one.
I mean, and a lot of times the bipolar is going to be after they're on their stimulants. First they're going to have ADHD kind of symptoms, and they're going to be put on the stimulants. They're going to have all these behavioral changes.
I didn't think about that.
And so, if you can just open up their airway, and all of a sudden, I have a TED Talk that actually describes a lot of this stuff. So
Right.
you'll find my TED Talk and watch that. It gives a good example of the life of someone that basically has a small jaw and how it affects all of these other aspects.
And plus, me and you have another whole hour discussing your TED Talk and stuff like that on another YouTube video. If you just put into YouTube or Google the skull-brain connection, it's actually the first one that pops up with me and Dr. Simmons. But okay, so we talked about
So the new one, that would be obstetricians.
OBGYN?
Well, I've got a grant from the NIH.
Okay.
We're monitoring pregnant women to see if we can identify the onset of sleep apnea during pregnancy by monitoring them every night, by them wearing a ring. And we have a software platform that keeps track of the data on a nightly basis. And all they have to do is wear this ring at night. And it's not, something that's sold it's not a commercial grade thing. It's medical grade kind of monitoring. And so we have a grant from the NIH because we realize that apnea during pregnancy can affect not just the mother, because then there's a higher chance of having gestational diabetes, gestational hypertension, maybe leading towards eclampsia, but also the fetus is at risk. Yeah. And so at the conference this year, we're going to actually have a lot of this information presented about the impact of sleep apnea during pregnancy itself.
And fetal development also?
Fetal development, yeah.
Wow.
And and also mandibular growth, and how that can be affected, and how you're going to have a higher chance of having apnea later on, once the child is delivered. So obstetricians is sort of a new area that I'm interested in getting the word out to.
Well, the other part is that I read that postpartum blues and postpartum depression in those people with sleep apnea or even undiagnosed sleep apnea is far more common in that population also.
Yeah, so when you're not getting proper sleep, your body doesn't go through the normal restoration that it needs.
Yeah.
And so all of these when you're asleep, your limbic system gets a chance to get rest and get rejuvenated. And when it's not getting proper rest, you're much more susceptible to having mood dysfunction during the day. And so anyone that's having any kind of psychiatric issue, postpartum depression, someone has to be screening for sleep. And when someone says, well, I can't sleep. Well, okay, would it be good to change that and intervene there? So actually another lecture, Dr. Dave McCarty is going to be lecturing on insomnia.
Yeah.
Because insomnia is highly neglected, and people are just throwing sleep aids and they're not looking at behavioral changes. There are so many different aspects that are involved with insomnia. But someone can't fall asleep or they can't stay asleep, that falls under insomnia. So
and perimenopausal symptoms also are worsened whenever there's sleep disruption too, for the OBGYN folks that are listening.
Right. Exactly. So
because a lot of people get low-bird, you're having like hormonal imbalance, and people think they're having hormonal imbalance. In reality, your hormones are a manifestation of fragmented sleep as well, right?
Well, it's not always. I mean, it's not to just neglect saying, okay, when a woman's going through menopause, there are hormonal changes.
Right.
But those are somewhat isolated in time in this transition.
Right.
But there's so much more involved. And yes, when you're not getting proper sleep, it is going to have its effect on hormone function.
Yeah, absolutely. And hormone sensitivity and the way that the liver even metabolizes hormones is all dependent on the quality of sleep as well. So we talked about OBGYNs, we talked about psychiatry, we talked about pediatrics. We haven't talked about ENT yet. I think that's pretty important,
Okay,
right?
so ENT,
Yeah.
a lot of ENT doctors have just a sort of a skewed perspective, and they'll say, okay, just tonsils and adenoids, or from a surgical standpoint, they used to cut away at the uvula. They would perform a uvulopalatine pharyngoplasty, and that turned out to, in the 90s, that was in vogue. But then it turned out that it really did not provide a substantial resolution of the problem. But what's real clear is that if someone's nose is not patent,
Yeah.
they're not going to breathe well. So ENT is crucial.
Yeah.
Even if the ENT doctor may not be able to provide the complete solution, they have to cover their part, because someone's not going to do well on CPAP,
Right.
or they're not going to do well on an oral appliance if they can't breathe through their nose. So frequently we need to have the ENT doctor go in and to deal with nasal obstruction. If someone has polyps, they need to get those removed. Most people have some degree of a deviated septum. So that, if that's all they're focusing in on, and if the ENT doctor is telling you, oh, I'm going to cure your sleep apnea by correcting your deviated septum, that's misguided. But if the deviated septum is really compromising nasal respiration, it may need to be corrected, but that alone is not going to resolve the whole problem. But ENT doctors should come to the conference. They're going to learn about Inspire, which is the hypoglossal nerve stimulator, which is put in by an ENT doctor. And there are other things that can be done. So Dr. Tran is going to be one of our lecturers. He's going to talk about
Christopher Cheng is the ENT here in Texas.
And he does frenulum releases. So looking at restricted mobility of the tongue and how an ENT doctor can help with that. It's controversial. Some dentists will say, some ENT doctors will say, oh, that's ridiculous. You don't need to do that. But it's not true. The thing is, not everybody needs to have a frenulum release, but there are some that do. And to understand when that should be performed and when not. And so
we'll talk about tongue frenulums right now. I know because the OBGYN and frenulum means something totally different than the ENT doctors. We're talking about tongue ties at this point, and so that's what we're talking about in from an ENT perspective. But any other specialties you wish?
Oh yeah, neurology.
Neurology, yeah.
I can't tell you how many of my colleagues will treat migraine that's triggered by sleep disorders just by giving more meds.
Or they give botulinum toxin
give
like Botox to alleviate some symptoms, but that can potentially trigger other sleep disruptions, right?
Well, it hasn't been really worked out that well. Theoretically, you think, geez, if you're relaxing the jaw with Botox, could you make the breathing worse?
Right.
No one's really demonstrated that, but so there is a paper out there in neurology that Dr. Bill Ando and I and a number of other people did a study on sleep bruxism, or on bruxism and TMD dysfunction and Botox, the use of Botox.
Right.
And at first, and I said exactly what you were alluding to, is that the Botox make things worse. So we were actually going to use apnea as an exclusion criteria for introduction, because we did sleep studies on all these individuals, with their Botox. And it turned out that all these patients that had bruxism and TMD dysfunction that were in the study, a high percentage of them had apnea at the get-go, so we couldn't use apnea as an exclusion criteria.
They're just not diagnosed.
Exactly.
But they ended up having sleep apnea. Right. A lot of people with clenching actually do have sleep apnea. It's just not diagnosed at the time, right?
Exactly.
So, yeah.
So I mentioned Dr. Ando. He's actually going to be giving one of the lectures for the consortium, restless leg syndrome, and also talking about parasomnias, the abnormal behaviors during sleep. But so neurologists, though, for, also fatigue and cognitive dysfunction, difficulty with concentration, and even seizures. If someone has seizures, that's a condition in and of itself. But the ability to get optimal control of your seizures is going to be influenced by whether the individual is sleep deprived. So if you have someone with sleep apnea and they're having breakthrough seizures, by improving their apnea or resolving it with treatment, you can improve their seizure control.
Wow. Yeah. That's really powerful. I don't think people really think of that, like seizures, and a lot of people can potentially have sleep apnea, and then if the apnea is better controlled, it actually improves the seizures.
Right.
Because right now there's so many people with multi-drug resistant epilepsy, but they've never had a sleep study done, which a lot of patients I see looks like that as well. Right? And I send them to you.
Just a real simple concept there is that you have a natural threshold for seizure. Someone that has epilepsy, there's a certain threshold that if the abnormal discharge goes beyond a certain threshold, then it goes into a seizure, right? That threshold is influenced by your sleep. So sometimes when someone's going to come into the lab to get an EEG study, the brainwave study, the instruction is to come in sleep deprived, because we know that sleep deprivation will increase the likelihood of having this abnormal discharge demonstrate itself in the EEG, right? It's already known that sleep deprivation can allow a seizure
Right.
to more likely statistically demonstrate itself. So imagine if you're sleep deprived all the time because you have a sleep abnormality such as sleep apnea, so that's lowering your seizure threshold. So by getting proper sleep, it raises it back up to its baseline level.
Which makes sense. So speaking of electricity, let's talk about the heart. A cardiologist. How can cardiologists benefit from
Oh
this?
gosh, atrial fibrillation. The onset of atrial fibrillation. The first thing to think about is, could it be from sleep apnea?
Yeah.
So the question is, well, how can sleep apnea cause atrial fibrillation? Well, when you have that increased vacuum that I talked about earlier in our discussion in the chest, it causes more blood to rush into the right side of the heart when the heart is in diastole, when it's relaxed and it's filling. That amount of filling is influenced by the negative pressure. So if you have more negative pressure in your chest, there's more venous return and the right side of the heart gets distended. Okay, so that includes the right atrium. So if the atrium gets distended, then the conduction may not be normal. So when a cardiologist does an echocardiogram, they're looking for chamber sizes.
Yeah.
And if it's greater than
enlargements.
what I think 4 point, I'm not a cardiologist. I think it's like, if it's more than like 4 or 4.4 centimeters, it's considered to be abnormal. They're doing that study during the day when the person's awake.
Yeah.
What's been demonstrated is that, and it's very few studies because they're hard to perform, that if you do echocardiography at night when someone's asleep and has sleep apnea, and at the point in which they have more negative pressure in their chest, there's enlargement of the right side of the heart to the point where the interventricular septum can shift from the right to the left. So the left ventricle cannot fill with as much blood, which means that you're going to get a drop in your systemic blood pressure during systole because there's less of an ejection out of your right side of the left side of the heart. But anyhow, you can go into AFib from sleep apnea, and there's a number of mechanisms, but I'm just describing the pressure one, which then causes transient enlargement of the right side of the heart for someone with AFib.
Well, you know, when I was trained, we were told to see that if someone has atrial fibrillation and potentially they have a dilated or enlarged atrium, then they likely have more chronic atrial fibrillation. But in my head, you know, chicken or the egg, it's like perhaps that the chronic atrial fibrillation is dilating the heart. But you're saying, well, it may not necessarily be. It may literally be like the inspiratory pressure. Like
Well, yeah, the vacuum in the airway, ultimately it's going to cause damage to the heart.
Wow.
So we know that sleep apnea can lead to congestive heart failure. And then once the person has heart failure, then they may have more of a complex apnea because they're going to have central apneic episodes. But that's a whole other discussion. These are things that we're going to touch on at the conference. Cardiologists really need to come to this because they're seeing end stages of what has been brewing for many years. And they need to be more involved on the preventive and improve outcome side of things. And some cardiologists recognize this. So once they start asking some questions, they get excited to the point where they now want to set up a sleep lab in their cardiology practice because, you know, there's like, well, economically, you know, insurance companies have cut back reimbursements. So doctors are looking for other ways to bring in more revenue. And they realize the epidemiology. They're like, oh my gosh, I have so many of these patients in my practice. I need to have my own sleep lab. The problem there is they're not sleep specialists and they're taking on the whole role of performing sleep. And then they'll do good for a certain number of patients, but by holding up this banner saying they're now doing sleep, a lot of patients, they may not manage optimally. But it's the fact that's even happening is a demonstration of the need of cardiologists to be more involved in sleep and to know when to refer and collaborate with other physicians that this is their focus, and collaborate with dentists. Some patients are going to do best with a dental appliance. You know, you have to control mandibular positioning by opening up this joint or the valve of the airway, changes what's going on in the chest, changes what goes on in the heart.
You know, this makes sense because when I was taught in med school, one of the things to look out for those people with undiagnosed sleep apnea is that they have diastolic hypertension. If their bottom number, if you will, on the blood pressure is high relative to the top number, then that's something that you want to look out for, even though the top number of the systolic pressure is actually normal. And now, like, that just kind of came back to my head as you're talking about this, which makes sense from a physiological perspective, right?
Well, yeah, I mean, so there's a lot to this. The question is, if these are things that are going on at night, why is there a ramification during the day?
Yeah.
Why doesn't it just stop? Eventually things build up, but let me just throw out one mechanism that's out there that hasn't been really elaborated on very much. When you have this distension of the right side of the heart, you end up putting out more atrial natriuretic peptide, okay, which is something that stimulates the kidneys to get rid of fluid.
Oh, okay.
Right. So during apnea, there may be more urine production, and then the person may be waking up to go to the bathroom, and they think it's a prostate problem, but the urologist says it's fine, but it's because of their obstructive breathing causing this distension of the heart, increased atrial natriuretic factor. So when you do that, you're losing sodium. All right.
Okay.
So when you lose sodium, then your adrenal glands, you're going to end up putting out more adrenal corticoids. You're going to have more aldosterone, and you're going to be trying to get more resorption of sodium.
Okay.
And that's a long acting. That's a long acting hormone. So you may be putting out more hormones to try to resorb the sodium to compensate for the sodium loss, but it's going to be prolonged into the daytime. And then we give medications like spironolactone and things like that to lower, the sodium. But why is it accumulating? It could be because of what's going on with breathing at night.
Right. So that's a big one for cardio and I guess nephrologists and urologists too, right? Putting the whole big picture together of how sleep really affects all these things. They're not going to isolate things.
Well, and then so nephrologists, a lot of their patients with kidney failure are going to have restless leg syndrome. And that's going to make it real hard for them to sleep. And then they have to sit down during dialysis and not move, and they're getting fidgety. And so there's issues with iron and restless leg syndrome and neuropathy and how it plays a role in all this. But the endocrinologist would be another type of physician that would definitely benefit, especially when you're talking about glucose control. Because when you have apnea, you put out more cortisol at night from the arousals and more adrenaline because you're getting your sleep disrupted and your heart rate keeps on jumping. That increased cortisol and adrenaline lead to insulin resistance.
Right. So this is the people who are like, I always have waking up with higher sugars while I haven't eaten anything, and then later throughout the day, like it drops. Right. That's sort of that
what they call it, samoji. Yeah, a lot of that increased stress. People were saying, well, why is this happening? They're looking at it isolated as a hormonal phenomena, not that it's in response to something else.
Sleep. Yeah.
So sleep apnea can increase these hormonal changes that cause insulin resistance. So by treating apnea, you can get better glycemic control.
One of the things that we noticed, because one of the things that we used to do quite a lot was looking at salivary cortisol curves throughout the 24 hours, right? And we're noticing that those people with real blunted salivary cortisol curves, the main holistic society calls it adrenal fatigue. And for me, it's a sleep fragmentation, meaning that those people with quote unquote these adrenal fatigue phenomenon with these cortisol curves, that's not sort of the beautiful, it goes up and comes down, but rather it's either blunted or there's failure to rise, right? And a lot of them also have paroxysm. They have a lot of grinding that goes on as well in the evening time. And so majority of those people we figure out actually have underlying, sleep disorder, not necessarily just sleep apnea, but some sort of sleep disorder that's keeping them not being able to fully get into that deep sleep in the evening time. And that's about 7-8 years ago we did that. And after a while, we stopped doing those tests, and we just send people to get sleep studies done after, which turned out to be far more beneficial as well. And so we talk about endocrinologists. Any other specialties?
Well, yeah, I mean, geez, rheumatologist.
Oh, rheumatologist. I think this is a big one. I think rheumatology has been a field that has been responsible for connecting everything together. I feel like rheumatology is almost isolated on the island as well, right? But let's talk about how rheumatology can really benefit from the Sleep Education Consortium.
Well, because a lot of these patients with chronic pain, their pain can be improved by dealing with their sleep. And a lot of patients with fibromyalgia, they have dysfunctional slow wave sleep. Your pain threshold is influenced
Yeah.
by your slow wave sleep. So if you don't get proper slow wave sleep, you're going to have a much lower pain threshold. So little aches and pains that you otherwise wouldn't feel because it would be filtered out by a nicely rested central nervous system, those signals are going to break through, and the person's going to have pain in areas where they shouldn't really be feeling it. And it's not because of inflammation. And that's sort of been this big puzzle. It's like, wow, we don't see anything perfectly wrong. Well,
yeah.
but if you start looking at their sleep, you'll see most of these patients have dysfunctional sleep. So if you improve their sleep, then they're going to be able to have better control of their pain.
Do you know if this is independent of an actual rheumatologic condition like RA or anything like that?
Yeah. So someone has rheumatoid arthritis.
Right.
You don't want to say they have fibromyalgia. It's like, well, wait, which one is it? Is it the rheumatoid arthritis? So this is actually separate. So could someone have that same kind of, someone says you have fibromyalgia and rheumatoid arthritis?
Yes.
I guess what the rheumatologist is saying is that your pain that you're experiencing is beyond the level of impact that I see from your arthritic condition, but it's independent of that. So in other words, it's so on top of whether you have arthritic, a true rheumatologic inflammatory condition or not, if you don't have one, you can have dysfunctional sleep, and then you're going to have fibromyalgia symptoms. I had one patient that was really impressive that the only thing I could find wrong with her is she had periodic leg movements of sleep.
Yeah.
And this was without restless leg syndrome symptoms.
Yeah.
But those leg twitching movements cause brief little arousals in her sleep. So I said, look, you don't have sleep apnea. You have this profound periodic leg movement disorder. I'm going to check your iron. Her iron was okay. She didn't have signs of a neuropathy.
Yeah.
And, I put her on medication to stop the leg movements.
Yeah.
Her fibromyalgia went away.
Yeah. This is a while ago. It was on the video, right? Yeah.
So it's so these things are all interrelated, but we know that fibromyalgia patients, they need to be assessed for their sleep.
Right. And so and beyond just fibromyalgia, but all rheumatologic conditions and rheumatologists deal with a lot of people in chronic pain and debility. Not addressing the sleep is really missing a big part in their overall quality of life, dramatic overall quality of life. And so, all right, we talked about rheumatologists. Any other specialists you think could be useful?
Gerontologists.
Geriatrics,
because as you get older, there are a lot of sleep issues that are occurring, and that will exacerbate other conditions. And we also know that Alzheimer's, for example, or any kind of dementia process is going to be enhanced by not getting proper sleep. Now, there's a lot of questions is there a tie-in? Are sleep disorders responsible for the dementia?
Right. What do you think?
Well, I think clearly, like everything else, there's a spectrum. All right. What we do know is that there's something called the lymphatic system. So that's like a lymphatic system of the brain, and it clears out toxins and various debris that accumulates within the brain. And the lymphatic system functions at its highest level of flow when you're in slow wave sleep. So if you're not having proper slow wave sleep, then there may not be the clearing of certain toxins. And if those toxins are going to be detrimental to neuronal health, those neurons are going to be more poisoned, if you will, and there may be a higher acceleration of getting fibrillary tangles and amyloid plaques and things like that may be accumulating in someone that's having Alzheimer's if they don't have proper slow wave sleep. This is still theoretical. I think there's some studies pointing to this. There are some animal models that are showing, animal models of Alzheimer's, that if you can change lymphatic flow, that you're going to decrease the progression of this neuronal degradation. So I think we don't have all the story architected out yet, but there clearly is a relationship. But what it is clear is that something like sundowning syndrome, where the elderly individual in a nursing facility, they're sleeping during the day and they're given meds to sleep during the day. Then they're waking up in the middle of the night and they're confused, and then they're going to be disoriented, and they don't have enough, because of the darkness, they don't have enough environmental cues to really understand where they are, and they're getting confused, and they have a lot of behavioral changes. So they're given more meds at night. So basically, there's nothing that's being placed to enhance their normal functioning. So what's been shown is if you take these elderly individuals and you have them exposed to bright light during the day, like outside,
Yeah.
and they're engaged in activities during the day,
Yeah.
and so that you more force a normal circadian rhythmicity by these external we call them zeitgebers, timekeepers of things that are going on in our environment. That helps maintain normal function and can decrease the occurrence of sundowning syndrome in the elderly. And that's just one example
Yeah.
of where geriatrics can be influenced by looking at sleep.
Right. And of course, it's the primary care doctors who are dealing with pretty much all these symptoms of the patients. It'd be really,
Family practice. I sort of assumed that was sort of a given. Family practice physicians should come to this conference. There's no question in my mind. So one thing to mention, for the dentist, the conference is 3 days, because the first day we're trying to get some of the basics of dentistry that maybe is beyond what the physicians need to know. And there's also hands-on where the dentists get to learn about doing the exam of the airway and learning about dental appliances. The second and third day are for both physicians and the dentist. So for physicians, it's a 2-day conference. For dentists, it's a 3-day. So really our discussion now is about physicians. So for those 2 days, a physician is going to learn so much about sleep that they've not been exposed to previously. It's going to be a mind opener. Last year, I remember an endocrinologist said, "Oh my gosh, it's like trying to drink out of a fire hose." There's so much information. And a lot of times people will come back again, but you get slides, you get materials to take home afterwards to go over the stuff. But I have people that are coming year after year because they realize that they didn't capture everything and they want to come back for more. But I think every clinician needs to learn about sleep, because every one of your patients sleep. They spend a third of your life basically sleeping, and there's so little time in a healthcare education teaching about it. On average, currently, over the 4 years of medical education, at most, the average is anywhere from 2.5 to 4 hours spent teaching medical students anything on sleep, whether it's normal sleep physiology or sleep pathology. And yet epidemiologically, it represents such a significant hindrance on our healthcare and our health. And it's not proportionally represented in our education.
yeah. And another group I'm going to talk about are pharmacists. And this is why I think pharmacists are really coming into importance. And so the world of pharmacy is changing pretty rapidly, especially with independent pharmacists. And the reason is because the way that things are going right now, the actual infrastructure in the business of pharmacy it requires a very big reform for the independent pharmacists to do what they currently do, because now you have Amazon Pharmacy and all the stuff like that. And the role of pharmacists should really go into the clinical side. The role of pharmacists actually is developed, and the term clinical pharmacy is actually developed to oversee what is really going on in the patient population. Pharmacists talk to their patients about symptoms and side effects all day long. And pharmacists there's a frustration in the pharmacy community not being able to collaborate with their other healthcare professionals on this. And part of the reason is because no one's really looking granular at the actual prescriptions that are there. Really good example. I had a pharmacist friend message me, "Hey, I want to talk to you about this patient." And obvious signs of, 10 cups of coffee a day, plus Ritalin, plus worsening bruxism, worsening grinding, right? And she was really concerned that this patient's having some caffeine toxicity. This patient ultimately ended up having a really bad, really severe sleep apnea on top of that. So a lot of what the pharmacists are actually seeing on the ground, talking with the patient, has a huge component in sleep disruption. And even those insomnia meds we talk about, right? They prescribe trazodone and all these different things. They're seeing multiple interactions that are going on. Another pharmacist called me about, "Hey, this person was prescribed this medication by the primary care, which is an antidepressant, bupropion. And at the same time, this person has a history of epilepsy, and the neurologist is prescribing these epilepsy medications. And bupropion actually worsened this person's epilepsy, but no one really caught it. And she was calling me because the neurologist wouldn't talk to her, her primary care wouldn't talk to her. We're on consult for something completely differently as well. And so I do feel that pharmacists have an enormous role in clinical care, that should be part of this conference as well. So
Yeah.
and we're now in this age of talking about sleep, and it's things like this are trending on TikTok. We have this Mewing trend. We have a Netflix documentary, and actually there's going to be another Netflix documentary on top of that. We have the book Breath by James Nestor that came out, and so I think a lot of what we're seeing right here is in the public knowledge, and it's up to the physicians and the dentists to educate ourselves so we can have much higher level of conversations, better quality conversations.
Let me express a scenario that I
Yeah.
hear about all the time, and it's very frustrating. There are dentists that will obtain a lot of education on sleep and actually know more than a typical physician.
Yeah.
And so they're going to sit down and they'll recognize the problem with their patient, and they're going to do all this explanation to the patient about the problem. And the patient now is a little bit confused, like, geez, they've been going to their primary care doctor for years, who's never mentioned any of this. And they're hearing this from a dentist. So they're trying to get some kind of opinion from the primary care doctor to see whether they should, try to get validation
Right.
from what the dentist was telling them.
Right.
And then once they go to the primary care doctor, in hearing that this is information they got from the dentist, a lot of times just totally disregard and tell the patient, yeah, no, don't worry about it. And they basically discredit what the dentist has just spent all this time doing to educate the patient. And this is so tragic because at that point, everything stops and the patient's pathology continues. So those primary care physicians shouldn't be rendering an opinion if they haven't really spent time learning. So, primary care physicians really need to learn about sleep disorders, internists or family practice doctors, and pediatricians, because pediatric dentists are really getting involved. Dr. Kevin Boyd is a pediatric, he's one of the lecturers. He's been really leading with a number of other people this whole effort to have early intervention orthodontics. Actually, Mariana Evans, she's an orthodontist from Pennsylvania that's going to be giving a lecture on this topic at our conference this year. But, if the mother then says, well, geez, the pediatric dentist is saying I should start doing all this stuff real early, and they talk to the pediatrician says, no, that's not unusual. Normally they wait, and may discredit and then guide the patient to go see another opinion to a more classically older orthodontist who doesn't understand these new airway concepts and does the extraction retraction type of orthodontics. And then the child ends up getting a compromised airway by getting a smaller mouth because the pediatrician didn't know. Mm-hmm. The pediatrician should be influencing to the earlier intervention. So, this knowledge needs to get out. And I'm glad that Netflix put out this because it's going to raise public opinion, and then the public will bring it to their dentist or to their physician, who then are going to be asked to render an opinion and may have not really yet established an opinion, but maybe as they try to do their little search, maybe they'll find the true answers. And so usually a lot of times physicians don't want to learn anything. Good example, restless legs. Physicians thought it was a made-up condition, and then they would poo-poo their patients with restless legs. But then when a few drugs were FDA approved for restless legs, there were more TV commercials. So now more patients were asking their physicians about restless legs who didn't know anything about the topic. And I've been giving lectures on various things for many years, and even educational for the pharmaceutical companies to teach about certain medications. We would do these dinner talks. And all of a sudden, all these doctors were showing up to these dinner talks on restless leg syndrome. Why? Because their patients were asking them questions, and now also they can go to a lecture and get answers to some of these questions. They can learn more about the condition. So public awareness helps to drive the advancement of the healthcare profession because physicians feel uncomfortable when they don't know the right answers. They may give you an answer just because they don't want to appear stupid, but underneath they realize they don't know, and then they'll seek out education on the topic. So I think we're moving in the right direction. It's just moving slower than I anticipated 30 years ago.
It's a multi-decade process. 30 years later, you get a Netflix documentary and changes different things, right? But I think the court of public opinion is really important to understand. is that people will be looking at this and asking higher quality questions. And we really have to be on the trend to explore those and create curiosity within our own organization, and it's hard right now. And it's hard because there's so much information that's out there. And we've moved into this age of hyper information. I mean, people thought internet, the World Wide Web, WWW, people thought the World Wide Web was the master source of information. Now we have AI. Now you have ChatGPT. Now we have Microsoft Copilot. We have Claude 2.0 and all these different large language models that are out there that's constantly extracting information, not just from the internet, but from you and me, all the time. And they are learning on large bodies of information. A few days ago, Apple just launched the pre-order for their Apple Vision, and then Apple actually is developing their own AI to actually be put into these vision models where people are actually learning like from a headset. And no one's going to care about TV screen sizes anymore because you can just drag and enlarge the screen size right in front of you with the headset now, right? So there's a hyper information that's coming that's even bigger than when the internet started with artificial intelligence. And one of the things that I'm going to talk about at the Sleep Education Consortium is how we as healthcare professionals can actually teach and use and create our own artificial intelligence engines and models to help each other between healthcare professionals and for the patients as well. And on top of that, how are we going to be teaching these language models to actually do the right thing? Meaning that AI, it's not just a tool. AI is a large body of knowledge, and it's up to us to actually train the artificial intelligence, right? And so there's a big concept with AI this year that I'm going to get into because I developed AI tools for collaborative medicine between healthcare professionals, between doctors and dentists and different specialties and orthodontists and et cetera, et cetera. And learning from what's been happening over the last few decades in terms of medical education is we're now able to really educate people on a much higher platform when we incorporate an AI engine that's able to inquire on the data. Meaning that, how many times have we been to a conference or watched a documentary and all this different things like that, where we're like, well, what did it say? What did that person say in that conference that one time, right? What was that? What was the thing that I saw? Now you can develop your own databases where we can actually provide an AI engine, whether it's OpenAI, ChatGPT, Microsoft, whatever, to inquire on the actual data. So Dr. Simmons and I did this where we actually created this AI engine that was able to inquire on previous years' information about the conference and what people talked about. And so that's a new age of learning right there. And it's actually inquiring on the knowledge base. And the term knowledge base is whatever the large language model is learning from, and then using a chat bot or a speaking bot to actually acquire knowledge from it, right? And so we're in this new age of hyper learning. This hyper learning can now be utilized as part of continuing medical education as well through AI engines and AI bots. So not only is this Sleep Education Consortium going to be a bunch of speakers, but the AI can actually learn from the conference and give you pieces of information that you think you either might have missed, or maybe you couldn't attend the whole thing, and you can actually chat with the bot on exactly what's covered during the conference, so every person could be up to date as well. So that's what I'm going to talk about at the Sleep Education Consortium. Now, let's go back to the mewing trend, and we'll close it out there. Is you got to meet John Mew.
Right, actually, yeah.
How was that experience?
It was fun. There was a dental organization, AAGO, and they had a conference in Phoenix a few weeks ago. And actually, I'm in a band.
Yeah, you play the guitar very well.
And I, with other healthcare professionals, dentists and physicians, oral surgeons, myofunctional therapists, and so we started a band a little over a year ago. We were all in a conference and talking about music. It's like, okay, actually this momentum had started before I got involved, but it's called the Pulmonauts. And so we actually had a concert at this conference that took place, and it was honoring Dr. Mew at the conference. And he gave pretty much almost half the conference with his presentation. But so we had our concert on that one of the evenings of the the conference, and he was right there, and that was so I got a chance to meet him in his 90s. He's very articulate and cognitively still completely with it, and he gave a profound story and history about the whole controversy that's out there.
Right, which is now on Netflix. Right. Thank you, everyone, for listening today or watching. If you're watching this on YouTube, I recommend everyone to go register for the Sleep Education Consortium if you're a healthcare professional. And once again, for the dentists and dental professions, there's extra content for this conference, specifically for the hands-on portion and for the physicians.
So there's two different registration pages. For the dentist, you go to dentalsleepconference.com. For the physician, you go to medicalsleepconference.com, right? And if you're a dental professional, but you're not necessarily a dentist, you go to the dental pathway. If you're a myofunctional therapist, you can go to the dental pathway, the 3-day conference. If you're a nurse practitioner or physician, go to the 2-day conference. And so there's two separate web pages, dentalsleepconference.com, medicalsleepconference.com.
Excellent. Well, thank you, Dr. Simmons, for being
My
on.
pleasure. Thank you for having me. This has been great.
Yeah, excellent. Once again, hopefully we'll see you at the conference. Bye-bye now.
Take care.